Okay, here we go. We're back. We're live. We're live for our panel with Dr. Robert Pearl and Dr. Jonathan Fisher. So the first question I'd like to ask you, which comes up quite often, which we call Healthcare 3.0, which is a term we use because, Web 3.0, which is the new web, what's the new healthcare? Give me some of the core components that you feel are needed in that new healthcare system. Dr. Pearl, please.
Well, I tend not to want to label something 1.0, 2.0, 3, because where does it start? Where does it stop? So I'd like to look at the evolution of where I think it needs to go, which in many ways leads to the 3.0. And I'm going to tie back into some of the things that Jonathan presented so brilliantly and the research that's been done so well. Let's take one piece, loneliness. I think he's talked about it a lot. The Surgeon General's talked about it a lot. People say it's equivalent to 15 cigarettes a day or something. If loneliness is seen as a problem, would you design physician offices isolated from each other? Or would you create spaces in which clinicians intersect with each other? Now, in Uncaring, I write a lot about the, in quotes, old doctor lounge, where some of this loneliness would be addressed, not because it was built into the system of the offices, because it was built into the system of the hospital. But those have gone away for a variety of economic reasons. Jonathan spoke a lot about depression, amazingly painful problem that is, I think, poorly talked about, maybe better understood, but poorly talked about by folks today. When I think of purpose, and depression, and I want to differentiate, there's certainly a biological depression that people experience that have nothing to do with the circumstances. But I want to speak more about the circumstances that lead to depression. And if you allow me to call it in parallel, because I no way want to blame people who have a chemical driver of that somehow they've created for themselves. But if we want to say there's at least a piece that's social or a piece in the social that augments the chemical, however you want to view it, and Jonathan will have some thoughts, he's an expert. To me, it has to tie into purpose. And is the current healthcare system designed to maximize purpose? Do we ask, how will a change influence my income? Or how will it change the health of my patients? And I think the current system, that's why I say I think we're all victims of that. So what does it start to look like? It starts to look like a group of clinicians who all bring expertise coming together to provide care. And in providing that care, they are able to overcome a belief from the past. In the past, we thought about quality, access, and service and cost as conflicting with each other. And in the 20th century, they did. And in the 21st, what do we think it is? They're synergistic. How do you lower cost in 3.0? You avoid heart attacks, strokes, cancer. We can talk about how you might avoid it, but the measure is very simple. Did the patient develop it or not? And if the patient didn't, how do we use that savings to now create a virtuous cycle to make the next set of investments? Quality. How do you best improve quality? By making investments in the changes that are going to avoid heart attacks, cancer, strokes, all the other diseases, avoid communication disease. We can go through the litany of things that sit in play. And that becomes the measure. You want to have frequent access. How could you design a system where I see you every 3 to 4 months based upon how many calendar months sit in between? What are you likely to have? Chronic disease. That's every single day. And if you don't yet have chronic disease, you have the factors that are going to lead to chronic disease. Why would I design an episodic system of care based upon a calendar rather than a continuous. And when you start to look at that, you start to look at technology. Technology isn't good or bad. Technology is how it's used. So in the 3.0 world, you're getting care constantly. You're improving your health on an ever-present basis. The physician and the team working with the physician are designed to be able to use modern technology to help you achieve that. There's measurement that occurs. And at the end of the day, we focus on purpose, which is no longer going to be reversing disease as it is today in American medicine, but it's based upon the ability to prevent disease, to maximize health, and to maximize wellness. It's a totally different ecosystem of care, and one for which I can't imagine we could be farther today. If 3.0 is the goal, we're at minus 1.0.
Wow, okay, I never heard it that way. Jonathan, what's your vision, or what needs to be the focus in this new healthcare system that we all desire?
So I'll give you my vision, and I have a question for Robbie as well. So first of all, there's an oxymoron there. So healthcare 3.0. So on the one hand, we're talking about health, which is a human or a physiologic occurrence. We're talking about care, which is the core emotional practice of healing and health. And then we have this technological sounding 3.0 with a digital space. And I understand the idea behind it, but it really, I think, pushes us in the wrong direction towards the technological, almost like a software upgrade 3.0. When we're looking at, we could look at the challenge we face now as an evolutionary one, or we can look at it as a cataclysmic one. So there's two ways to make change. And I'm interested to talk about that. I think cataclysmic would be far too dangerous and ugly. A lot of people are going to get hurt. And so we're stuck with an incremental model right now. I personally view systems as organisms, as bodies, as human bodies, and I really find that model useful. Even looking at Engel's biopsychosocial model of stress for lifestyle medicine. We go down to the cellular and subcellular level, we go to the societal and global level, and thankfully healthcare systems are looking at environmental impact. So if we take that approach, instead of a technological approach, which is taking solutions from well-meaning investors and AI developers and trying to stick them onto our system, starting from the basic principle of what does health look like? What does ideal function look like? Going back to the basics. And so if you look at a body, there are multiple organs working in synergy that are communicating with neurochemical signals. So in our healthcare system, we need to have clarity of roles that support each other. So we need to get clear on what's the role of the doctor in our system. It's no longer clear. Doctors have now become clerics and become billers and become transcriptionists, which is getting to what Robbie was saying, away from our purpose. That was not our purpose going into this field. What's the role of a leader? Is the role of a leader to look at numbers on a spreadsheet and then to come around and use carrots and sticks and threats and promises? Or is it to be a human being, in a sense, helping bring together all of the organs within the organization and bringing some synergy there? So my focus would be on getting simple again. What does human health look like? So looking at the terminology of our healthcare system, 100 years ago, there was this focus on the biomedical model. In the 19-teens, that was modern medicine is, I think it was the Ochsner report, talking about our role as healers is to look at the brokenness of the individual and fix it. And as Dr. Pearl was alluding to, what about preventative medicine, which fortunately, it's really 40 years old, not too much more than that in this country, with the work of Andrew Weil and then Dean Ornish, fortunately starting it. But why has nothing changed in 40 years? I think it has to do with the incentives. So what incentive, Robbie, what incentive can we give those primary care doctors, the cardiologists, to do preventative care that is going to save the dollars so that we don't have this churning model of having to see more and more patients? That's my question. So for me, healthcare 3.0 is rooted in human health and physiologic factors, common sense, including healing spaces, including a team approach to care, which is taught not to middle-aged doctors who are going to reject it, but to first-year medical students, saying, we teach our business students in this country how to solve problems on teams, but we teach medical students to take tests by themselves, and it's how much they know. And so I think we need to get with that program. I'll pause there.
So this is great because we now have an area of disagreement. So this is good. Johannes want us to do that. So I think about the difference between a middleman mentality and a leadership. And I believe that American medicine today is filled with the middleman mentality. The middleman mentality looks at the crack on your driveway and asks, how do I pave it over? Leadership says there's a root growing somewhere under that. I have to pull up the asphalt. I have to dig out the roots, and I have to prevent the problem from getting worse in the future. The middleman can make a lot of money. They can introduce a system, a tool, a device. There's a lot of middlemen, and American medicine has become the middleman. And the middleman assumes that there is no real fix and that change can only happen by increments. I don't think it's possible. That's where you and I may disagree. I don't really know. Because I think that every small step forward, every incentive program for the primary care physician ends up failing. Because there is no way. I can pay you $10 more to do hemoglobin A1C, but what about hypertension? But what about smoking? But what about diet? I can go on forever and come up with new metrics and new ways. And I think we actually make the problems worse, not better, often as a consequence of doing that. I think there needs to be major, you call it transformation, call it disruption, and I'll give you one step that then puts everything else in order, and that's moving from fee-for-service to capitation. Because if you bring a group of doctors together and you capitate them, they can do the right thing. And by doctors, other clinicians, other providers, nurses, everyone else, because you've now aligned all of those incentives. We do better when our patients do better. There's never a conflict of interest. We prevent a heart attack, we do better, they do better. We control hypertension, we do better, they do better. They eat a better diet, we do better, they do better. There's no place where the system starts to contradict itself. And once you bring smart, motivated people together with that goal, you start to restore purpose. Once you do that, they find ways to collaborate and cooperate. As long as people can make money by the inefficiencies, I think about it as friction, generates a lot of heat but no energy. That's okay for them, but it doesn't work. And so I think that what we need to do is once that process starts, and then create the space to allow people to figure out how will we use technology within it. Why should Alexa not be our strongest partner? So we don't have to see patients every day in the office because Alexa can do it for us, but under our direction with a singular purpose. How do I increase the health? Now, you may think it's diet. I may think it's exercise. Johannes may think it's meditation. All right, let's get together and talk about it. Because I'm not going to benefit, you're not going to benefit, he's not going to benefit. We're going to all benefit together, including our patient, by being able to accomplish that. And I think that that's the big transformation. And you can't do it a little bit. You can't Monday, Wednesday, and Friday practice fee-for-service, and Tuesday and Thursday practice capitation. It has to be all or none, and everyone wants a half little step. And I think that that's the big thing that needs to sit in place. And when that explodes, we'll call it a disruption, we'll call it a strategic inflection point, we'll call it a transformation, call it what you want. Once we change the way that healthcare is actually paid at the delivery system level, I believe everything else will fall in place because people have the right purpose and motivation. Hope I'm wrong, by the way, because it's easier to do small steps. I just don't think they're going to succeed.
Okay, we heard that before with Dr. Furman, actually, in a different sense, a different setting. But some of the questions I get also often is, well, it seems to be there's too much money in it, big money, big pharma, big investments and all that, that nobody's really interested in what you say, Dr. Furman.
So, there are a lot of things I can say are wrong in life, and many religions are based upon all of that. But I see things from a reality perspective. There is a lot of money in medicine. So how do we change that in a way that is now going to drive it differently? And that's, again, if we can't clamor to change capitation, but as soon as you change capitation, as an example, take a simple situation like the hospital. The last place you want most patients is the hospital. Yeah, there's some who are so sick, you have no choice, they should be in the hospital. How do we build a hospital at home? Not for a balance sheet to lower the hospital cost or whatever it's going to be, because we can provide better care. And when you start to ask, how do you do a hospital at home in a way that's compassionate? You have to recognize some families got a lot of loved ones around and some don't. So how do we build the support? And how do we put in place monitors, not to replace people, but to augment people? Everything we do starts to have this purpose towards a goal. In the end, how would we like to get care? Yeah, we'd like to have 17 of our cousins there so we have continuous care by a human being who loves us all the time. But what happens if we live alone? What happens if we don't have a whole lot of friends? What are we going to do in that circumstance? Well, there's ways we can support it. May not be as good, but that's the reality. And again, I have such belief in clinicians that when they have a problem, they will solve the problem. But when you give them the wrong problem with the wrong motivation, the wrong outcome, they can't solve it. And they struggle and they twist over each other themselves. And I think that is part of what we call burnout. And as soon as you change all that and you align them, and now they have a common purpose in view, and we can debate, as I say, exactly how to do it, but we all go home feeling better at the end of the day than we go home feeling today. The system is just simply so broken, but it's not going to be that hard to fix. I mean, it's going to be hard to fix, but not hard to start the process of fixing.
Dr. Fisher, please go ahead and counter that. And my first thought when you talked was, where do you find these leaders?
Oh, you talk about that.
But let's go there maybe later. Dr. Fisher, go ahead.
Yeah, well, Robbie, you touched on having people in the house and having that human connection. My concern is that if you were to change the system right now towards capitation, physicians are caught in the middle, in a sense. We already have a 15-minute visit. 8 minutes of that is spent on the computer. Half of it is fumbling around. And so I'm worried that if we shift the model radically like that, without setting up for success beforehand, there's going to be a massive egress. Last year, tens of thousands of physicians left the job market. And my concern is that if physicians aren't the ones leading this change, and instead it's handed from the top down, we're going to see that egress. I totally agree.
Exact opposite. The capitation is for the physician. They're setting it, they're creating it. And the 8 minutes on the computer, you don't need it anymore. You want it on a smart tablet to record information so that you have it to provide great care. You're not doing it to document something for an insurance company. Did you have 5 levels of examination or only 3? But is it a 3.0 modifier? It's crazy how we bill and create all the forms that sit in play. Get rid of it all. I talk about it happening in one fell swoop. It's an impossibility to occur. Sorry, Jonathan, but I just wanted to make that point.
Oh, that's perfect. I do agree that we have to look at what Amazon's doing well and bring companies like Apple in. Our current systems, our electronic medical systems, were, as you referenced, were not designed from the bottom up with the intention of giving care. And so that is one example where I think a radical change would be effective. I think it would be widely embraced. Have physicians who are caring for patients design a system that has as little interruption of care as possible. I also think patients want it. When I want data, I want to look at my ring to tell me, how's my sleep last night? And I want to know how my heart rate is. So can we get better at having patients get the care where they want it, when they want it? That's where the future is. Think about Amazon delivering things to your door. We're not going back to brick and mortar in that sense. And I don't think healthcare is going to be able to stay in the brick and mortar world. We have to embrace that technology. So I'm with you on that.
Which Brings me to the next question, which a lot of people ask, and I know a lot of them are worried about. If they hear Amazon, Google, and whoever gets in the game, oh my God, our data is all over the place. Healthcare data, right? It's being sold to the highest bidder, which is already. What's your take on that, both? And maybe we shorten questions because a lot more. And both of you, if you're okay, we stay a little longer. Would love that. If okay with you.
Yeah.
You're
So
absolutely
what about the data security issue that is very deeply connected with this?
Yeah, well, data security always has two sides to it. There are the intentionally malevolent people, and they're the ones who are just careless and make mistakes. There's legislation that allows us to keep the malevolence out, particularly as the big retail players become part of the insurance world. Very strict guardrails sitting in there. The challenge in any piece of data is the people who are just make an opening available to someone who wants to steal it and make all of that happen. But that's something that exists right now. I think the biggest problem that I see is there's no place that each of our sets of information about ourselves is available. How do you provide great preventive services if you don't know what services someone's received? How do you provide great care for a chronic disease if they have 11 different providers of care, none of whom share a common information? It's just not possible. And so I do think that we need a solution. Now, the question is going to be, how do you get there? And I believe very strongly, and I've been hypercritical of the current EHR companies, that you have to force them to open what's called their application programming interfaces, their APIs. And that when they do that, third-party developers will come along. They'll figure out how to extract information from all the systems. And who owns the data? The patient. That's who owns the patient. Wherever you go, your data is available to your care deliverers. How do you provide great care with that information about what's gone on? And right now it is so cumbersome and complex, it takes so long to get to it. It's not that hard. You know, it's interesting. I like to backpack a lot and to hike a lot. You go to the top of the mountain in some South American country, and there's an ATM machine, and you know exactly how much money I have in my bank account in the United States, and they'll give it to me in local currency at exactly the right exchange rate. That's a lot bigger problem than taking data entered by clinicians and by hospitals and by, laboratories that have been licensed, and figuring out how to extract information from each of those APIs and put into a common system. That's where I think it needs to go. And is there a privacy risk? Yeah, but I'm not sure the privacy risk would be any greater under that kind of system. I think it actually would be less than it exists today.
Okay, Fisher?
I don't have anything good to add to that excellent answer.
Okay, let's talk about another topic which came up too, about chronic disease obviously affects, not mostly, but to a large degree, the communities that cannot afford, I want to say, proper healthcare, especially in terms of the chronic health issues, lifestyle-based, and so on. What's the solution there?
I can tell you that in our system, there is an equal attention to either free clinics or low-cost clinics that our clinicians are encouraged to staff and populate. We have funding from both within our system and also private funding support that. That's in the Charlotte community, and I think it's an ethical question, and I'm hopeful that this generation of ethical leaders is going to focus on raising up everyone and not just those who can afford care.
I think what you might be referring to, as much as the issue of the uninsured, is the issue of the social determinants of health, and the fact that if you live in a lot of communities, you can't eat good food, no matter what it's going to be, or if you don't have enough income, you can't buy the healthy food that sits in play. Your zip code as much determines your health outcomes as the medical care you receive and all the pieces that are there. The hard part is right now, doctors, healthcare systems, they are being destroyed. The idea of adding the smallest little thing to their plate is an impossibility. And so, yes, there's some little tiny fixes that can be done to address it. But I think that medicine has to move. And that's why, again, I keep focusing on this capitation, because it comes out of that, because now addressing social determinants of health become really important if people are capitated inside your system that sits there. I think that the societal needs and the medical needs, we have to start recognizing how much they overlap. If you don't have a job, you don't have good health. I can give you 5 different reasons why you don't have good health, but let's all agree you're not going to be healthy if you don't have a job. If you're homeless, you don't have a good job. You know, it's interesting. I gave a talk in Washington, D.C. at a community health center, a big meeting, but run by a community health center. And the person I gave a great talk about diabetes and hypertension and all the chronic diseases. And the woman there put me in my place, and she said, you know, we surveyed all of our people that we take care of about their 10 biggest healthcare problems, and not a single thing you said today, Dr. Pearl, made their list. They want to know, how am I going to stay warm in winter? How am I going to feed my kids? What am I going to do when my child has a problem, but I don't have a health insurance at my job? They had a whole list of 10 things that in their mind was health, that came long before anything that we might have put or learned in our medical school training. So it's where I think that once you start capitating, once you start make that movement happen, 3.0, 5.0, 9.0, it doesn't matter what you want to call it. At some point you realize how small our pond is, and that if we really want to be able to be successful at being able to generate the dollars that we want by delivering health and wellness to people, we've got to get outside our exam rooms, get outside the patient's home, and get into the communities that we serve. And that's where I think we have to work with elected officials. We have to work with community leaders to accomplish that. Today, I don't even want to mention it because doctors are so overwhelmed. But if you ask what's going to come after a capitated system that's going to focus on chronic disease and focus on prevention and avoiding complications and reducing heart attacks and strokes, and now you start to generate added dollars, I'm not going to put them back into more chronic disease programs. I'm going to put into the communities around us, not because I'm a nice guy, but because that's going to be most beneficial for me and for my patients.
Dr. Fisher?
I have nothing to add there.
Okay, so let's maybe close with the previous question. Where do we find these leaders? And please, your closing statement, Dr. Fisher, or whatever you like to close with for today.
Yeah, this is the challenge that I'm excited about. We can't see change without effective leadership. And right now, I think we have a crisis of effective leadership. So first, we need to shine a spotlight on those leaders that we think are doing a good job, that are leading healthcare systems towards growth and community, in addition to profits. I think that the best hospital systems have physicians at the helm. There is data to support that in terms of safety and cost, and also have nurses at the helm. The point is to have people who have clinical experience in leadership. So that's a mindset shift that the Cleveland Clinic has helped kind of move along there, setting the model there. Leadership skills need to be taught in medical school, not just for those who want to go into leadership, but as a life skill. I think that coaching, any modern leader has a coach, but in healthcare, we seem to be behind the game there. We're not treating leaders in healthcare with the same kind of, as a prize fighter in a sense. And I think that includes encouraging leaders to take time off, to demonstrate self-care. And so coaching, having a culture of coaching is very important in leadership. And the other thing is we often find ourselves as physicians volunteered into leadership positions. In fact, I would say the majority of doctors are told, by the way, in addition to your current responsibilities, you're going to be the head of such and such a department. And this is often done with little or no training, preparation, and often against their will. And so this is a setup for failure. So we need to start from the beginning, having systems that value the physician voice as the people who know what care can look like, and also train medical students from the earliest stage, also through residency, have career growth as another priority. That's not something that most leaders look at when they think of their doctors. They think, we're going to hire you. Congratulations, work for another 40 years until you retire and you're done. But we know that dissatisfaction happens when we don't have a sense of personal growth. We also need to retain physicians before they'll become leaders. To do that, we have to give more flexibility in the individual schedule. So my interest is in non-invasive and preventative cardiology. What we know is that if you're my leader and you give me 10 or 20% of my schedule to focus just on that I will be more productive. I'll be more energized. And so creating systems with more flexibility rather than a cookie cutter approach. In terms of my takeaway point, I can tell you that I personally experienced some wonderful leaders in medical school and in residency, and I also had many that you might call toxic and then did a fair amount of harm to me and to many of my colleagues. And it wasn't through a fault of their own. It was an old model of leadership that said, as the old model in the military said, it's a command and conquer, it's a control type of a style that's based on harsh criticism. It's almost like a carrot approach. And I'm optimistic that there's a shift now, as we understand human psychology better, that a more supportive, nurturing approach, almost like a parent to a child. What we know from attachment theory in children is that the harsh, critical approach doesn't work. It leads to problems. So let's train our leaders to be more empathic, more compassionate, and to recognize that that's not in conflict with making profits for your system. In fact, it'll support the system and profits. Thank you.
Thank you.
I agree with everything Jonathan has just said. About 15 years ago, I wrote an article in the Harvard Business Review about why a month of fourth-year medical school, which is basically a waste of time often, particularly in the era of going around doing all your interviews, there's at least a month in there that's wasted. Should be spent in a business school, learning about how to lead, how to do teams, how to communicate, a whole set of skills that as Jonathan said, every physician needs. But I also think that we're talking now about I'll call it an uber level of leadership, which is the ability to lead a true transformation. And that's a very complex and difficult skill. And I'm going to start in a strange place, which is the sine qua non of leadership, is that every leader needs one thing: followers. If you don't have followers, you're not a leader. You're just a wanderer. And that I think what's different in medicine is that it's not the leader who attracts the followers, it's the followers who need to demand the leader. And when people start saying in organizations, what we really want is a strong, effective leader who can accomplish this. We know it's possible, but we also recognize that in the healthcare complexity of the 21st century, it's a very sophisticated skill bringing hundreds of people together, cutting the human body opening, putting toxic drugs in place, putting them in these machines, all the parts that are there. These are not simple skills. And if followers don't want a strong, effective leader, it's never going to work. And so it has to start, I think, with a ground up swell, demanding it. Once it's there, we know how to teach it in business school. Right now, the Forbes series I'm writing is actually about leadership. And I write about the brain, the heart, and the spine, 3 anatomic structures that leaders are going to need. And in my mind, the brain's job in a leadership of transformation is to create a vision, let people see it, let them understand what's possible, make it attractive enough that they want to go there. But they're going to have some fear. And so the heart's job, through stories, through patient anecdotes, is to give them the energy and emotion to overcome that fear, to be able to move forward even though they can't be guaranteed what's sitting at the opposite side. And then the truth of the matter is, and the reality is, that no matter how optimistic, brave, courageous you are, at some point you're going to want to stop. And the job of the leader is to keep you moving forward with the realization that, as difficult as it may be, once we can get to the other side, that what will be in place will be so much better, that we can make burnout a distant memory from the past, that that we can basically return the mission and purpose of medicine, not in the context of a 20th century model, with what's available in the 21st. Thank you, Jonathan, for engaging this today. Thank you, Johannes, for organizing it all. And once again, if anyone wants more information, my website's robertpearlmd.com. Thank you so much for having us today.
Thank you so much. And Jonathan, share also your website. And then I have one last very, very short question.
Yeah, best is to connect with me on LinkedIn, Jonathan Fisher, MD, or Happy Heart MD. Happy Heart MD. You'll find it one word. I'm on all social media.
My last question, should physicians and healthcare providers walk the talk, integrate lifestyle medicine themselves, and especially should they have their own health coach to support them on that path? Quick question, both of you.
Yes. Quick answer. Yes. It's something I wish I had all along. I think my mental health would have been much better 5 years in, 10 years in, if I had had any of that. My physical health would have been better, and I would have been in a better position to coach other people. You can't coach other people in things you haven't experienced yourself. So my answer is a yes.
My answer is that every human being needs to focus on health and lifestyle. They have to be able to eat well, exercise well, do the mental relaxation that's needed, have the relationships. We go on the whole long list. And doctors should be human beings. They are human beings. So we all need this. It doesn't matter whether you have an MD, an RN, or some other degree sitting after your particular name. And I've never seen an area where coaches aren't helpful. You know, I have a trainer, and I've gotten so much stronger with a trainer than I did by myself. Exactly which coaches, how to pick your coaches, what area you want to focus on, whether it's in your relationship or your diet or your exercise. I think that's a different question. There's economics involved for a lot of people sitting in play. But if the question is, does a coach make you better than you can do it by yourself? The answer is always yes.
Thank you so much. Talking about leaders, we found two. It's a good start in here right now. So thank you so much, both of you. This was amazing. I hope we can repeat that. I love it. The feedback is amazing too. And it gets everybody like, you know, not just discussing, but hey, there's a vision. There's somebody out there that knows what needs to be done. So we just need to support you and come together. So thank you again. Wonderful for you being here.
Thank you again
so much.
Thank you so much. Thank you.
It's an honor.